Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, we're looking at health inequalities and how frontline clinicians, practices and policymakers can make evidence-based decisions to tackle inequality in healthcare. I'm speaking to Dr. John Ford and Dr. Liam Loftus from the Health Equity Evidence Centre at Queen Mary University in London about how they're aiming to make the evidence on what works when it comes to addressing health inequalities more accessible. The Health Equity Evidence Centre uses machine learning to analyse the vast amount of research and literature that's available, and the team at the centre turns that information into actionable insights for GPs, other frontline clinicians, system leaders and policymakers. John and Liam explain how all this works in practice, the resources they have available, and how this can help GPs, practices and primary care networks in their day-to-day work. They also talk about projects they're currently working on, including how GP funding inequalities can be addressed, and how they hope to establish a solid evidence base for what works when it comes to tackling health inequalities in the future. Before we start, just a quick message to say that MIMS Learning Live Digital is taking place online across 4 evenings from the 10th to the 13th of March. If you need some help keeping up to date with clinical practice, our colleagues from our sister site MIMS Learning can help with this series of evening webinars. You'll have the chance to earn up to 6 CPD hours from the comfort of your own home or practice, with presentations from expert speakers who are passionate about their areas of expertise. For more information and to register for your free place today, visit mimslearninglive.com/digital. I'm delighted to be joined on the podcast now by Dr. John Ford, who is a Senior Clinical Lecturer in Health Equity at Queen Mary University of London and Director of the Health Equity Evidence Centre, and Dr. Liam Loftus, who's a GP and Associate Director for Policy and Practice Engagement at the Health Equity Evidence Centre. Thank you both for coming on the podcast.
Thank you for having us, Emma.
Thanks, Emma.
John, let's perhaps start with you. What exactly is the Health Equity Evidence Centre and why did you set it up?
The Health Equity Evidence Centre is an intimate, independent academic collaboration hosted by Queen Mary University of London, and we focus on generating evidence on what works to address health and care inequalities. A big part of what we do is using machine learning to produce living evidence maps, and these are maps which map out what works to address health inequalities. And at the moment, we're focusing particularly on primary care and what works to address primary care inequalities. The reason for setting it up is really twofold. First of all, I've been studying inequalities for about 10 years. So my reflections are that we've had loads and loads and loads of data and evidence describing the problem of inequalities, but far less research and evidence on what works to address inequalities. And even the evidence that does exist is kind of scattered across multiple disciplines and multiple areas. So we wanted to try and pull a lot of this evidence together in one place. And secondly, I started my research career off working for NICE, reviewing new drugs which were coming to market for the NHS. I literally spent months screening through tens of thousands, maybe even hundreds of thousands of research papers. And I always thought there must be a quicker and more efficient way to do that. And part of that is us using machine learning within the Evidence Centre to try and navigate through all this emerging research and evidence.
Liam, how did you get involved with the Health Equity Evidence Centre?
For me, my background was more in sort of policy than academic specifically. So I'd done a number of fellowships locally, nationally. I think during these fellowships and when I was sat in these policy-making spaces, I was always really interested to see how we use evidence in policy to give us the best chance of success. So when I heard what John was doing at the Health Equity Evidence Centre, I was really interested. I felt this was right up my street. It sort of builds on my passion for tackling health and healthcare inequalities, but also using evidence in policy. So I wanted to get involved. I wanted to see how we could take some of this academic work directly to policymakers and practitioners in order to sort of bring it to life and really sort of make sure they have the information available in order to make evidence-informed decisions when it comes to tackling health inequalities.
How is it that you first got interested in, involved in health inequalities in the first place? Maybe start with you, John, on that one.
Yes, I grew up in a suburb of Glasgow called Coatbridge. I had a great childhood, but Coatbridge itself was a fairly socioeconomically disadvantaged area. It had suffered decades of post-industrial unemployment, poor housing, poor education. And as I went through medical school, I think I was increasingly convicted that the structures within society are what leads some people to have poor education, limited opportunities, low incomes, poor housing, poor health, inevitably shorter lives. Whereas for others, there's an accumulation of advantages throughout their life, which leads to better health and well-being. And so these kind of structural factors which drive health inequalities are what got me interested in the whole field around what works to address them. I especially think about the structural factors within healthcare, which may be funding, workforce workload, which lead to the inequalities we then see in access, quality, and outcomes for patients.
And how about you, Liam? How did you get interested in this line of work?
In this sense, I always tend to come back to, well, what is the definition of health inequalities? And a common one being that these are unfair and avoidable differences in health between different groups of people. And throughout my early life, throughout my medical career, I saw the impact that these unfair and avoidable differences were having on the people that I would meet. And I think the fact that, firstly, they're unfair, it speaks to my sort of sense of justice and really wanting to do something about this. But secondly, and importantly, that these are avoidable. There are things that we can do here. So it's something that's always been important to me, both in a clinical sense when I'm sat in my consulting room, but also in a policy sense when we're thinking about those structures that John talked about and how we shape those structures to reduce these unfair and avoidable differences.
There's obviously like a lot of evidence out there around health inequalities. I mean, we hear people talking about health inequalities all the time in kind of policy spaces as well, and stuff about what works, perhaps what doesn't. So how do you go about collating all of that evidence? Where do you actually start?
There's more and more being published all the time. So certainly when you look at the data, there's been something like a 280% increase in the number of research articles alone being published on primary care inequalities over the past 10 years. Navigating all of this for practitioners, policymakers is almost impossible. If you think there's maybe close to about 5,000 articles being published every year, how you expect anyone to keep on top of that? So what we've done is we've trained a machine learning algorithm to help navigate us through this. And that then produces something called living evidence maps, which are essentially a map which shows what works across different domains of disadvantage. So for example, ethnicity, deprivation, age, sex, etc. And across different types of interventions. So it might be across whether it's cancer screening, whether it's funding, staff and workforce services. And that means at our fingertips, we've got a large set of data and evidence, which we then turn into evidence briefs for the NHS. So we then synthesize that together and produce evidence briefs around what works across different topics.
We've heard a lot about AI, artificial intelligence, about how it's going to change the NHS, how it's going to change the world, really, every job. So how do you actually use this machine learning? What kind of system is it? What do you put in and what do you get out at the end?
Yeah, so there's been lots of hype about machine learning. I think a lot of it tends to overpromise and underdeliver. And we're really excited about what we do because it's a really concrete example of how machine learning is really helping us to advance our field of work. So we use some software called Epi Reviewer, which is developed by the Epicenter at UCL. And what we do is we use some of our previous research or previous literature reviews. We feed that into the software and that trains an algorithm. So that's a training material, which gives the algorithm an idea of what we're looking for. Once the algorithm understands the types of research studies we're interested in, the ones which speak to what works to address inequalities, it can then search through something like 240 million research articles within the space of a few minutes. And it essentially prioritizes them. So it gives us at the top of the pile the articles which are most similar to what works to address inequalities or training material. And that means that as researchers, we have to only spend a day or two a month looking at the top of the pile and picking out the best of the research articles. And because we're able to do this every month, we call them living in that they're always up to date. They don't go out of date. And it means that we're able then to produce these evidence maps, which are now publicly available and anyone around the world can use them.
Basically, the machine learning, the algorithm, it's looking for things that work in practice to tackle inequalities. Is that right? So that's kind of what its priority is when it's searching through all this data. Yeah,
we've done various research in the past, all looking at what works to address inequalities. So we know the types of research we're interested in. And based on that previous research, we then use that to train the algorithm. And once software has understood the algorithm, it can then employ that algorithm on 250 million different articles. We would call it more augmentation rather than automation. So, we use what machines are good for, which are screening through millions of articles. But actually we do what researchers are good at, which is the intellectual thinking and the synthesis. So it's not a fully automated process, but we do what machines are good at, which is digesting large, vast quantities of data, and then the researchers do the intellectual part.
Because obviously you also employ researchers at the centre. So what is their role as part of this? What do they then do with all this data that gets spat out of your machine learning system?
So we've got a really mixed multidisciplinary team within the centre. We've got a group of researchers that manage the algorithm and which look at the research which is coming through. So they manually look through every study, make sure it's actually on topic, label it, and then goes into our living evidence maps. We have researchers which do the synthesis part, which look at how do we combine results from different studies into one overall evidence review. But we've also got clinical researchers as part of the team, and they're really key to identifying the important questions and helping us to interpret and present data in a meaningful way.
Because on your website, you talk about the fact that you handle evidence differently than traditional academic review methods, and you use the principle of transferable evidence. What does that actually mean? Is this what you're talking about with these living maps?
Not quite. So the living evidence maps come from our machine learning. So the idea of transferable evidence is, how do we logically apply evidence from a different field or area into another area and be transparent about it? So to give you a really practical example around health inequalities, so something comes up time and again is this idea that if we design high agency interventions, they tend to increase inequalities. So what I mean by high agency interventions are interventions which require patients to jump through lots of hoops to benefit from services. We know that they tend to increase inequalities. So for example, if we have an exercise referral scheme and a patient has to get an appointment with their GP, turn up to the appointment, get a referral, arrange transport, turn up to a number of sessions, there's lots of hoops there, and it tends to benefit a certain group and community. Whereas if we're designing a atrial fibrillation screening program, for example, then if we can design it in ways where there's fewer hoops to jump through, we're more likely to capture a diverse population. So that might mean doing things like opportunistic screening when people are having the flu jabs or collecting their prescriptions, or when they're in the surgery for whatever reason. So that doesn't require them having to book appointments and arrange transport and turn up at a specific time. So it's how we use these transferable principles so that when we're then doing a review of, it might be something like how to address inequalities in referrals, how do we use those principles across different topics rather than coming up with evidence reviews which just say, there's a lack of research, more research is needed.
Yeah, that makes a lot of sense. So basically, you've obviously ended up with all of this data, all this information. How do you translate all of that into something meaningful for people to use in their day-to-day work?
Good question, Emma. I think there's a number of ways in which we do that, but one of the most concrete and tangible ways is through our evidence briefs. So we produce a range of evidence briefs on a range of topics. So to give an example, how do we best support people who frequently attend emergency departments, for example? And within each of those evidence briefs, all of which are sort of freely available on our website, we start with a very sort of digestible summary of the background. So what's the context here? What does the evidence tell us? And then secondly, and importantly, we finish our evidence briefs with some very clear recommendations. So there's a table of evidence-informed recommendations about what we think will make a difference in this area, so what works to make a difference. And those recommendations are sort of put next to a specific target audience, which might be anyone from a GP or a clinician working in a practice, right the way up to national level NHS England, for example. And also each of these recommendations has what is called a grade certainty. And that is a measure that we use that sort of communicates the strength of evidence for each recommendation. So I guess when you pull all of this together in one place, as we do with an evidence brief, these outputs are sort of specifically designed for either practitioners or policymakers, and we try to tailor them in the best ways that we can to support people to use all of this vast amounts of evidence in their work when they're tackling one of these problems.
There's obviously lots of things you could look at, though, for those evidence briefs. I mean, how have you decided which areas to focus on first? I mean, I'm sure that library of evidence briefs will grow as time goes on, but how have you decided which things to highlight first?
One of the great things about being hosted by an academic institution is that we want to bring the kind of academic rigor to what we do. Actually, in the inequality space, there's lots and lots and lots happening, lots of new initiatives being started, but they often don't lack the rigorous, robust evidence and evaluation. So within our evidence briefs, we draw heavily on academic evidence published from across the world, trying to build up the evidence that way. And then we support that with what we call grey literature. So that's non-academic evidence. But again, we focus on evidence interventions and services which have a robust and relevant evidence base. So that tends to be they've got quantitative data showing the impact of their services with qualitative data which backs up the positive impact on lived experience, for example.
What are some of the biggest challenges you face in doing all of this? What are some of the difficulties you've come across?
It took us about 18 months to build the algorithm. So actually, setting up this machine learning approach wasn't necessarily a quick activity. Although now that we've set it up, we've become a lot more efficient. And there's still challenges with navigating just a large quantity of data. But using this idea of transferable evidence does help us with that.
I would probably add to that, John. I think in terms of when we think about how the evidence is then used by policymakers and practitioners, we know that they are very busy people. I very much understand the challenges they face, having sat in sort of both camps previously. It can be hard in both of those roles to try and create the headspace required to think about how can we think differently or improve what we're doing, as opposed to focusing on the very immediate here and now challenges. So I guess in the context of this, my response would be that there are so many people who are already working on health inequalities and doing great work at local, regional, national level and in their practices. I hope that some of our work at the Health Equity Evidence Centre will actually make it easier for those people to do some of the stuff they're doing already, potentially even quicker, and also really help them to focus their short amount of time and energy on the things that will probably make the biggest difference when it comes to tackling some of these differences.
John, I just wanted to ask you about your algorithm. So obviously you said that was quite difficult to set up. Is it something that needs to be tweaked as time goes on?
Every time we add new evidence, the algorithm updates. So it's a constantly changing algorithm. So let's say there's a new emerging inequality that starts, then we can add, as we add more and more evidence to our living evidence maps, the algorithm continually updates. And that's part of the challenge. That's why it took us so long to establish it, is that actually our initial training material and algorithms just weren't that accurate or precise. And so it took us a while to train, retrain, and hone the algorithm so that it identified exactly the types of studies that we were interested in.
And Liam, you were talking there about the fact that you hope this work will make it easier for GPs and others, policymakers as well, to actually do their jobs and maybe start to actually tackle health inequalities. Have you got any examples of how some of the work you've done could help GPs in particular, primary care networks perhaps, how it could help them to improve care?
Definitely. So I've got a very personal example, in fact. So a few years ago now, I was in my practice. I really wanted to do a piece of work around how could we improve the uptake of health checks for people with severe mental illness. And at that stage, in all honesty, I wasn't quite sure where to start. So I did a bit of searching around, a bit of speaking to people, and I came up with a few of my sort of own ideas for what might work, and then sort of put them into practice, give them a go. But then I guess if you fast forward a few years, now at the Health Equity Evidence Centre, we have an evidence brief that talks about what we think works to improve the uptake of these checks. And I guess had that have been available a few years back when I was doing my project, because not only would I have started with a really good summary of the context, but I then also would have had evidence-informed ideas on how to do it, which would give me the best chance of success. So I guess the work that we've done would prompt me, sat in my surgery, to look at things like, well, how are we best using our computer systems to highlight these patients in reception? Are we thinking about flexibility in appointment times, even through to thinking about, well, what role could care navigators play in this process? So I guess what I would say is that there's probably a lot of work happening in practices and PCNs around the country in the space of areas where we already have evidence briefs. So if you're already working on something or you're thinking about kicking off a project in health inequalities, then it's definitely worth a look on our website if you're looking for a good summary and some good suggestions about what we think works in this area.
You also talked about the fact that you obviously make recommendations in these evidence briefs for politicians, policymakers, system leaders. How would you like to see them using the work you're doing?
You're absolutely right. So within all of these works, particularly the evidence briefs, we try and be as specific as the evidence allows us to about the recommendations, including who those are aimed at. Some of the work that we do in the evidence briefs we do are more focused at that either system level or national level. So we've done a lot of work around sort of funding models that address inequalities. And that, I guess, is a particularly hot topic at the moment within general practice, given the growing calls to reform the Carr-Hill formula, for example. Also, we do a lot of work that lends itself quite nicely to either system leaders or trust leaders. So thinking about how trusts can be an anchor institution in order to impact positively upon the social determinants of health in their work. So I guess in answer to your question, health inequalities essentially is and should be everyone's business, whether you're working at the top of the tree nationally or you're working yourself in a practice. We try and cater for all of those people across the breadth of the system. And I can sort of guarantee if you were to take a look at some of the stuff that we do and you're working in this area, I think you'll find plenty of stuff that will be helpful for your work.
John, what are the plans for the future? How do you see the Health Equity Evidence Centre growing? What are you hoping to do in the coming years?
So we're doing lots of work around some of these structural factors which drive particularly general practice inequalities. So things like general practice funding, workforce inequalities, and what's driving some of the workforce inequalities we're seeing. Did some work on things like social needs screening in general practice. So, how do we collect and use social information better in general practice? Because we know a lot of GP consultations are taken up with social factors. Some work around improving mental health for Black communities as well. We've also got a large program of work around how do we shift quality improvement within the NHS to be more equity focused as well.
What work are you specifically doing on Carr-Hill reform and funding reform for general practice?
Yeah, good question. So we've done lots of work over the past few years looking at both funding reform and workforce reform as well. I think something that we're passionate about is how we try and address some of these funding inequalities. I think some of our reflections is that actually the income streams within general practice are so complex that actually care is needed in terms of how we tweak different elements of the funding ecosystem that general practice have. Clearly, Carr-Hill reform is needed. At the minute, it focuses on reimbursing practices for their workload rather than necessarily patient needs. And so from our perspective, we'd much prefer a Carr-Hill formula which focuses on patient needs and follows the patients as they go around. I think that would also allow practices to invest in things like prevention, especially early on in terms of things like MSK and mental health, which we know are particularly intrinsically associated with disadvantage and poverty. But I think there's also lots of other parts of the general practice income which contribute to the funding inequalities as well, whether that's the distribution of dispensing practices, whether it's QOF, whether it's locally enhanced services, etc., etc. So I think it also needs to be looked at in the round rather than just focusing purely on Carr-Hill reform.
What would you like to see happen as a result of all the work you're doing?
Our mission is really to build a better understanding around what works to address health and care inequalities. From our experience, it's really clear that there's no silver bullet. It's much more around how we mature our understanding around what works. And certainly the way I see it is that, certainly the evidence around what works to address health and care inequalities is very much in its infancy at the minute, especially compared to lots of other disciplines. And so our aim is to try and help mature that evidence base. I guess we're really keen to work with ICBs, national, local policymakers and practitioners to help understand what works and to build that evidence base.
I think from being sat both in the clinical and policy space previously, I've seen how much people probably want to use evidence to inform what they're doing. But in this space, I've seen how hard it can be too. And I think that's for all the reasons we've talked about today around the vastness of the evidence, how difficult it is to navigate. I think we're moving towards a position now with some of the work that we're doing where actually it's making it easier for policymakers and practitioners to be able to make more sort of evidence-informed decisions about their work. That's something that both John and I are very interested in, developing that evidence base, but also supporting people out there to really take these ideas on board and run with them.
Some of the problems that people encounter day to day in their practice, they can seem quite intractable, can't they? They're deep-rooted, embedded, they seem difficult to deal with. And when people are very, very busy, it feels like a mountain to climb to try and start picking through how to help and address these problems. But I guess what you're trying to do is to say, look, here are some ideas that are evidence-based to make it easier for people to do this work. Is that what you'd sum it up as?
Yeah, well, precisely. And we're trying to cater for everyone, no matter what part in the system they play. So for some people, it may be that they're frontline practitioners and they're just wanting some help on addressing inequalities in cervical screening, for example. And we've got some very practical help there.
Yeah.
But equally, we know that some of these inequalities are driven by structural determinants of funding inequalities or workforce distribution, factors like that. And we've got specific data and evidence targeting national policymakers. I guess from my perspective, some of the work we've done previously looked at the National Health Inequality Strategy, which was implemented in the early 2000s. And actually, we've got really great evidence that taking action on inequalities makes a difference. And so evidence from that period showed that inequalities in life expectancy reduced by 6 months, inequalities in infant mortality also reduced. So we know progress is possible, but it takes us all working together and all playing our part, no matter where we are in the system, to make progress.
Things have kind of gone a bit backwards on that, though, haven't they, over the last decade or so?
Yes, certainly over the past 10 years, we've seen a stagnation of life expectancy where, for decades and centuries, we've been having improving life expectancy. That's all leveled off. And we know that for some groups, especially women living in most deprived areas of England, their life expectancy has actually decreased. I think we're faced with a real challenge around how we try and solve that.
The work you're doing could maybe help unpick some of the reasons behind that and what actually happened to cause that compared with what maybe happened at the start of the 2000s where things going the other way.
Part of the challenge of unpicking it is that there's so much which happens at the same time. So if you think about the policy space, the introduction of things like Sure Start, but there's also income and tax reform. We had health action zones back in 20 years ago as well. So there's so much happening. It's difficult to identify the active ingredients about what made it work or not. My gut feeling is that actually the most important things were actually having a multi-level, multi-partnership approach and sustain it over a decent amount of time with some data and evidence to back it up is probably what made it more effective, rather than thinking there was some kind of magic ingredient which led to the shift in inequalities.
And so if anyone's listening to this who's interested in the work you've done and thinks it could help them in their work, where would you recommend them start? How can they best use the information you've made available?
Please do check out our website. So it's readily available if you just Google the Health Equity Evidence Centre. We've got a library of resources there, both evidence briefs, blogs, data insights, plus all our contact details are there. So please do get in touch.
There's a great summary from John. I would say, please head to the website. Also, please don't be afraid to reach out as well. John, I, and the rest of the team are really keen to see what we can do to support people doing the great work in their areas, wherever that area may be. So please don't be afraid to reach out and get in touch.
Thank you both so much for coming on the podcast. I really appreciate your time.
Thanks, Emma.
Thanks for having us, Emma.
Well, that's it for this week. Thanks for listening, and thanks again to John and Liam for taking the time to talk with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.